Hi, folks, it's Beth Wright, and I'm providing you a podcast for Unit 4, Chapter 14, and NUR 237. So, this chapter should be a review for you for several of the medications, but we're talking about inflammation and medicines that are going to be used for that. And I think it's important just to recall or remember the body's response to inflammation, because that's what we're talking about. These medicines are going to do something with that whole inflammatory response. And so thinking about what happens with the inflammatory response is going to be important. So let's talk about it. The inflammatory response activates when the tissue is injured, either by bacteria, trauma, toxins, heat, or any other substance. The damaged cells release chemicals including histamine, bradykins, and prostaglandins. And these chemicals help with that whole inflammatory process. So they cause blood vessels to leak fluid into the tissue that causes swelling. They help isolate the foreign substances from further contact with the body tissue. Now, in all of that help, we know that with that swelling, that definitely is where our edema comes from, and it's where our pain comes from as well. So it's, the body's trying to help, but at the same time, it's going to hurt as well. The chemicals also attract white blood cells, phagocytes, to help eat the microorganisms in dead and damaged cells, and we call that phagocytosis. Of course, the phagocytes eventually die. Pus is formed from a collection of dead tissue, dead bacteria, and live or dead phagocytes. And then, of course, we have fever that's produced from the pyrogens that affect the hypothalamus. Now, this is a picture just demonstrating what happens with the platelets when we have an injury there. And if you see on the right hand side, the activated platelets, when we have an injury, start to adhere to that injured part. And then, they start forming a network, if you will. And they start that aggregate, meaning that they clot together, they form together, aggregate together to surround that injured area. And then the third one just shows you where it's a platelet plug or a thrombus, again, to surround that area to keep it from bleeding and all that good stuff. So, the prostaglandins are what we are talking about in this one, and they are cell mediators that participate in that inflammatory response. And when you think about cell mediators, just think about mediating. What is a mediator? That's somebody who helps, with pulling things together, resolving conflict, that kind of thing. And so let's think about the prostaglandins as trying to do that in that inflammatory process. And they are derived from the COX-1 and COX-2 enzymes. That's cyclooxygenase enzymes. And there are two types. There's the COX-1. They're very abundant. They protect the gastric mucosa. They make the platelets stick together, and they decrease renal perfusion with vasoconstriction. The COX-2 is responsible for the inflammation and fever that occurs with an inflammatory process. Both causes a decrease in the renal perfusion. So when we hear COX-2, we should think about inflammation and pain. So we have our meds here that are non-selective COX-1 and COX-2 inhibitors that shuts down that whole COX-1 and COX-2 process so that the prostaglandins are then not coming to the rescue in the inflammation or inflammatory process. These are sometimes known as antiprostaglandins as well. So there's a table 14.1, and definitely don't want you to try to memorize that at all. Just want you to take a look at it, and I just, put up there the prostaglandin 2s just to, have a discussion about it. Look at what those prostaglandins, I mean, first of all, there's several different prostaglandins, but just with these in particular, the PGE2s, they cause in the body bronchodilation. They're gastroprotective. They increase the GI smooth muscle activity. They increase the sensitivity to the pain, increase body temperature, and cause vasodilation. Whereas you have some others of those prostaglandins that might cause vasoconstriction. Some of them causes the aggregation of platelets. And again, aggregation is that clumping together of the platelets. And, of course, that's a sequence there that occurs when we have an inflammation going on. So, again, just thinking about what goes on when we have an inflammatory process. I mean, it's very complex, but we've got lots of things that come to the rescue, and we, with those things that come to the rescue, sometimes, again, it causes the body different problems. And so they've invented these medications to help cut off that part of the inflammatory process. Now, here are your exemplars. You've got your NSAIDs, and we're talking specifically about the Oxycam derivatives, the meloxicam, the acetic acid derivatives, the indomethacin, the diclofenac, sodium, and the ketorolac. And then we've got the selective COX-2 inhibitors, the celecoxib medications. So these are the ones that we're going to be talking about. You've already studied about the salicylates, your aspirin products, acetaminophen, and the propionic acid derivatives like your ibuprofen. So those, those may you may see those come up from time to time, and those are medicines that are frequently used. So we need to know about those other medications as well. So our general NSAID mechanisms of action: it inhibits prostaglandin synthesis in the central nervous system and peripheral nervous system. So it inhibits COX-1 and COX-2 enzymes, which is required for that prostaglandin production. It relieves the pain by acting centrally and peripherally to block pain impulse transmission. And it relieves the fever. And again, aspirin and non-selective NSAIDs also have that anti-platelet effect. They prevent that aggregation of the platelets. So, when we do that, when we block that clumping together of the platelets, then what can happen to patients? We have to think about that. We certainly can see bleeding, and so signs and symptoms, we're going to see bruising. We've got to look at the gums because those are tender. That's a tender tissue area for bleeding. The skin for bleeding, petechiae, that kind of thing. Hematomas. We need to teach patients about being careful with shaving and, clumsiness like I am. Again, you know that acetaminophen is not an NSAID, and it does not have that anti-inflammatory properties like your other ones do. Okay, so let's talk about meloxicam. It is a COX-1, COX-2 inhibitor, and it's used for osteoarthritis and rheumatoid arthritis. And it can be used in children age 2 and older. So it produces that anti-inflammatory, analgesic, and antipyretic effects, although you don't see it used for the fever part. It's not recommended in severe renal impairment. Adverse effects can be respiratory issues, dyspnea, hemoptysis, bronchospasms, pharyngitis, rhinitis. We can also have hematological issues like bleeding, platelet inhibition, decreased hemoglobin hematocrit, bone marrow depression, and edema. We can also have GI issues, nausea, dyspepsia, diarrhea, vomiting, and diarrhea. And we can also have cardiovascular issues with this as well. So we've got to be sure that we assess patients for all of those adverse effects. Does have a black box warning with it that it can produce cardiovascular events and GI bleeding. All these drugs are going to have that, so we got to be watching for that. Cardiovascular events, are they having any chest pain? We got to do our vital signs, look at an EKG, so those kinds of things. For GI bleeding, we got to check the stool for blood, make sure, there's not anything like that going on as well. It's contraindicated. It should not be administered to anybody with an aspirin allergy, and it's also contraindicated for post-op patients who are undergoing coronary artery bypass surgery, the CABG. Also, it's contraindicated if there's renal issues if the GFR is less than 20. It's definitely not recommended. So, we're going to evaluate the client on their adverse effects and therapeutic effectiveness for all of these medicines, of course. And teaching is a big part of this. We got to teach the patient to take this drug with foods to help decrease that irritation. Only take the prescribed dose. They should not operate machinery, heavy equipment, that kind of thing, until they know how the drug affects them because of dizziness and drowsiness as a possibility of occurring. Because of the hematological aspects of this, they need to report any kind of sore throat problems, and for respiratory issues, any kind of dyspnea, cardiac, need to recommend, reporting any kind of edema, and of course for the GI issues, the tarry stool, any kind of black, dark stools, they need to report to their healthcare provider. Indomethacin is the acetic acid derivative, and it's inhibits the COX-1, COX-2 enzymes. It's used for pain. It's also used for some other things. It's administered to relieve pain associated with rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, which is an inflammatory process of the vertebra in the spine, causes some of the vertebrae in the spine to fuse together. It's also used for bursitis, tendinitis, and gouty arthritis. Also, it's interesting enough that it's used for neonates who are premature infants, if you will, to produce closure of the patent ductus arteriosus. So, in patent ductus arteriosus, as abnormal blood flow occurs between two of the major arteries connected to the heart. Before birth, the two major arteries, the aorta and the pulmonary artery, are connected by a blood vessel called the ductus arteriosus. And of course, this vessel is an essential part of fetal blood circulation. Within minutes or up to a few days after birth, the vessel is supposed to close as a part of the normal change occurring in the baby's circulation. But in some babies, that does not close and it remains open, and that's where the name patent comes in. Um, the opening allows oxygen-rich blood from the aorta to mix with oxygen-poor blood from the pulmonary artery, and that puts a strain on the heart and increases the blood pressure in the lungs of the baby. So they have found that the indomethacin actually helps close that. Isn't that cool? Now, with indomethacin, there's a black box warning issues. It's, again, with the cardiovascular issues that can cause a thrombotic effect, which could lead to an MI or a stroke. So we got to assess the patient for any signs and symptoms of that, and also GI bleed assessment. With administration, we're going to administer oral indomethacin with meals, or even with an antacid due to the gastric irritation that it causes. Patients with gout should not take the sustained release preparation of this medicine. And patients with a history of proctitis or rectal bleeding should not use rectal suppositories of this. The IV administration requires a dilution of 1 milligram with 1 milliliter of sterile water or normal saline. It's necessary to administer the dose over a 5 to 10 second period. Got to have good IV access to avoid that extravasation. And the storage of the oral prep is done in a light protected container, and that's essential. Adverse effects of indomethacin and all of the acetic acid derivatives is the GI bleed and bleeding ulcer. Abdominal pain, distension, vomiting may occur, so we got to be assessing the patient for that. Central nervous system adverse effects can be headache, dizziness, somnolence, and insomnia. Patients can be at risk for renal impairment and also a decreased clotting time. With IV preparation, we got to watch about severe respiratory adverse effects, and that can be, pulmonary hemorrhage. So, if somebody's got hemoptysis or coughing up blood, we've got a problem there. We got to teach about taking this with food or an antacid, which again, that's something different with a medicine, isn't it? We got to report adverse effects, teach them about that with chest pain, weakness, or disorientation. Not to operate machinery due to dizziness or the somnolence. Report sore throat, fever, rash, weight gain, or tarry stools to the healthcare provider. And we want to also evaluate effectiveness and evaluate for those adverse effects. The ketorolac, which is something we see a lot given it we have it as injectable, oral, or intranasal, but this medicine's given a lot, especially in the emergency room, because it has similar properties as morphine and for pain medication. So instead of using a narcotic, you'll see this used a whole lot in the emergency setting. It's contraindicated for high-risk bleeding, so definitely no labor delivery or before or during any kind of major surgery or cardiovascular accidents, because it could, the stroke, cardiovascular accident is a stroke, and with that we're talking about, that that stroke could be a hemorrhagic stroke. So also, folks on aspirin should not take it, and it does have a black box warning about the GI irritation, the GI bleed, or perforation can occur with this. Ketorolac should always be given initially by an IM or IV route, and it's limited for the use of 5 days, and dosage limitations, so we got to start with the lowest dose. The oral therapy is used only as a continuation of parenteral therapy. Celecoxib is your selective COX-2 inhibitor, and that's used for acute and long-term treatment of arthritis, ankylosing spondylitis, dysmenorrhea, and the adenomatosis polyposis. And contraindicated with severe renal, known to allergies of the sulfonamides and NSAIDs, aspirins, and we don't give that preoperatively or to patients with the CABG, the coronary artery bypass. Adverse effects, the CNS effects can be a headache, dizziness, somnolence, and insomnia. Some patients may note an ophthalmic change with the administration of this drug. Again, the patients are at risk for myocardial infarction and a cerebral vascular accident or a stroke. There is a black box warning with this medication regarding the cardiac and vascular risk. There's also dermatological adverse effects such as rash, pruritus, sweating, dry mucous membranes, and stomatitis. Dyspepsia and GI bleed can occur with this medication as well. Anaphylactic reactions can occur with this as well. So again, we got to teach the patients administer the medicine with food or meals to prevent gastric upset. Take it as prescribed. Don't operate heavy machinery. Report a sore throat, rash, itching, weight gain, swelling of the feet and ankles, and changes in the vision to the healthcare provider. And of course, as always, we want to evaluate effectiveness and for those adverse effects. Now, gouty arthritis is an issue with the uric acid, and that uric acid is a byproduct of protein metabolism. They call this the disease of the kings because it's a defect in the purine metabolism, which results in an inability to metabolize uric acid. And purine is found in foods like organ meats and game meat and wine and beer, things like that. So that's why they call it the disease of the kings. It can also, gouty arthritis can also be an issue, a side effect of cancer and chemotherapy. So you might remember the tumor lysis syndrome, where the uric acid is elevated and patients can't excrete it. The uric acid is in the tissues of feet and kidneys. So when we think about that, that's you usually see gout appear in the big toe, the great toe, the big toe. And with the kidneys, what it can cause is stones. And it can actually be so severe that it can cause acute renal failure. So our exemplars here are colchicine, allopurinol, the buxostat, and probenecid. So let's talk about colchicine. That prevents and treats gout. It works by decreasing leukocytes into the body tissue containing uric crystals. It can be given IV and oral. The dose with those two are not the same, so we've got to be aware of that. They don't recommend IM or sub-Q because it's very irritating to the tissue. It's toxic to bone marrow, so We shouldn't exceed the dose greater than 7 days use because of that. The dose does need to be decreased with renal and liver impaired. It works by causing diarrhea to get the uric acid out. Also, we need the urine to be alkaline, and we need to increase those fluids. The dose is reduced by a half for folks 70 years and older, and it should be adjusted for severe renal impaired. It is contraindicated given concurrently with cyclosporins, like that's used for organ donor recipients. Adverse effects, again, are GI issues, nausea, vomiting, abdominal pain, dyspepsia, hematological issues, bone marrow depression, aplastic anemia, and that's where all the cells are involved, the red blood cells, the white blood cells, platelets, and they're not produced. It can also cause hepatotoxicity or liver failure, peripheral neuropathy, alopecia with a hair loss, rash, purpura, which is your big bruising like petechia. It's the big petechia, purpura is. Myopathy with your, muscles having issues, and weakness. And we've got to watch for fluid and electrolyte imbalance with this as well. So teaching with colchicine is going to be to take as prescribed, and they need to take it at the onset of the acute gout symptoms. They need to take one dose at the acute flare-up, and then the second dose an hour later. It does not mix with grapefruit, and they should not drink that or alcohol. Gastric effects are common with this, so they got to watch about the abdominal pain if it's becomes severe, severe diarrhea, and muscle weakness. Those need to be reported. Also, we need to talk to them about the bone marrow depression, so any kind of, fatigue, their increased risk for bleeding or increased risk for infection. We've got to talk to them about that, and they need to see the healthcare provider. If they get a sore throat, they have bleeding going on. Also, we need to teach them about the low purine diet, avoiding beer, alcohol, organ meats, and game meats, sardines, anchovies, scallops, asparagus, spinach, and peas. Okay, the allopurinol is probably what you're going to see more often given for gout, and that's used to prevent and treat gout. It inhibits the enzyme that is responsible for the conversion of purines to uric acid. Sometimes you'll see this given with chemotherapy because we know gout is a possible side effect, and that increased uric acid is an increased side effect. For elderly, they need to take at least 2,000 milliliters per day of fluid to help flush the system. For renal impaired patients, the dose is reduced. It is contraindicated in the hemochromatosis, which is where the body absorbs too much iron. Adverse effects for allopurinol have several. There's CNS adverse effects such as drowsiness, headache, and vertigo. Hematological effects are agranulocytosis, aplastic anemia, and bone marrow depression. Most common GI effect is nausea, vomiting, diarrhea, and abdominal pain. Hepatotoxicity and renal insufficiency are also risk factors with this. So with teaching, we got to teach to have at least 2,000 mLs of fluid in and output out per day. We need to tell them to decrease, to report any kind of decrease of urine output or cloudy urine, because that could be, that they're developing uric acid stones. They need to report any kind of rash or skin eruptions. Again, about the not driving, operating heavy equipment until they know how it affects them. And they need to get, get in there to get some, to their healthcare provider, get some labs drawn for uric acid levels, liver enzymes, and creatinine done, and a GFR. The febuxostat is a selective and selectively inhibits the xanthine oxidase, and it's one of the newest ones out that's been developed for gout. It has hepatotoxicity, is an adverse effects, and cardiac events need to be assessed for patients taking that as well. And then last but not least, the probenecid increases urine excretion of uric acid, but it is not for the acute attacks. It's used for chronic. When started, it may cause acute gout until the serum level decreases. We also see this med, probenecid, that's combined with other medicines such as penicillin, because it helps keep the medicine in the body longer. Okay, that concludes your podcast.